Welcome. Today we are going to learn how to reduce a knee dislocation. Knee dislocation is an orthopedic emergency that needs urgent attention. They are seen as high energy traumatic injuries and are characterized by a high rate of neurovascular injury. Diagnosis is made clinically with careful assessment of the limb neurovascular status. X-rays are done for the diagnosis of the knee dislocation, and treatment includes an urgent reduction and stabilization with assessment of limb perfusion followed by delayed ligamentous reconstruction. It is seen that around 50% of the knee dislocations spontaneously reduce before their arrival to the ER. There is an incidence of around 25% incidence of common peroneal nerve injury, 60% incidence of associated fractures, and 40 to 50% incidence of vascular injury. And if this vascular injury is left untreated for more than 8 hours, the chance of amputation goes up by 86%. Now, a 45-year-old obese male patient who presented with a history of road traffic accident was brought to the ER with a history of trauma to left knee, and the complaints were of left knee pain, swelling, and inability to move the left knee. So the residents on duty, they ordered the trauma profile, that were the knee X-rays were ordered, AP and lateral views. So here you can see the X-rays of the patient, the AP and the lateral view of the patient. And here in the AP view, one can see that there is an overlapping of the distal femur over the proximal tibia. And in the lateral view, the diagnosis is quite clear, and knee dislocation is appreciated. Now uh, the direction of the proximal tibia to the direction of distal femur will help us to diagnose the direction of the dislocation. Here in the lateral view, you can clearly make out that the distal femur has moved posteriorly and the tibia has moved anteriorly. So this will be an anterior knee dislocation. So similarly, depending upon the direction, the knee dislocation could be either anterior, posterior, or lateral or medial. So now I shall demonstrate the reduction technique for the knee dislocation. Here you can see, before going to the knee reduction, I am assessing the neurovascular status of the limb. And here you can see that there is a foot drop, CPN palsy, and I am checking for the distal pulses, the dorsalis pedis artery and the posterior tibial artery. So in this patient, both the pulses were not felt at the at the beginning and prior to reduction. So this patient had a foot drop, CPN palsy, with absent peripheral pulses to begin with. Because the patient is obese, one cannot appreciate a lot of deformity. So my assistant will give counter traction by holding to the thigh, and I am holding the leg of the patient with, here I have put my left hand beneath the distal femur, and I'm trying to hold the leg with my right hand. So here I'm catching hold of the distal femur, and here I'm trying to translate the distal femur anteriorly over the tibia, and my assistant also grabs the leg. So this will be the reduction that has happened in here. Once the reduction has happened, you can see the deformity that was previously there has disappeared. So post reduction, again we have to do a careful neurovascular examination and again look for the peripheral pulses and compare with the opposite side. And here the patient is unable to dorsiflex the ankle and the foot. So this is CPN palsy. He is able to do it on the opposite side, but not on his injured left side. So this is a foot drop or CPN palsy, which is seen in around 25% of knee dislocations. And again, post reduction, uh, checking for pulses is very important. In this patient, they were absent. So once this is done, once the knee dislocation has been reduced, we have to immobilize the limb. Here I'm using an above knee Kramer wire splint. Before that, I'm applying cotton layer over the limb. So important thing about application of this above knee Kramer wire splint is that this should be well padded, and the bony prominences should be covered, and we're trying to take care that the Kramer wire splint is comfortable for the patient. So ample amount of cotton layers are applied over the patient's limb. So here cotton is being applied over the foot of the patient. Now important thing about this immobilization is that we have to immobilize it in around 20 to 30 degrees of knee flexion. So here I'm bending the Kramer wire splint so as to achieve around 30 degrees of knee flexion in the Kramer wire splint. So we are securing the Kramer wire splint over the limb of the patient with the help of roll bandages. So now we would be applying roll bandages and securing the Kramer wire splint over the limb of the. So after application of the Kramer wire splint, the patient will be again sent for a check X-ray so as to confirm a reduction. So on the left hand side of the screen we have the pre-reduction X-ray where we see the knee dislocation, and on the right hand of the screen you can see the post-reduction check X-ray where we find that the knee dislocation has been reduced. Now if we see the X-ray carefully in the AP view, we find that there is an avulsion fracture in the area of the tibial spine, indicating an avulsion injury of either the ACL or the PCL. Now, immediately once the X-ray confirms about the reduction of the knee dislocation, the next thing that we do would be a CT angiography. So we did a CT angiography of the lower limb, and luckily this patient had a normal popliteal artery, a normal anterior and posterior tibial artery flow to his left lower limb. So this is very important, that in a knee dislocation patient, we have to immediately reduce the knee dislocation and document the time period in which the dislocation was reduced, and also we have to carefully assess the vascularity of the limb. Despite the presence of the distal pulses, one may miss a vascular injury. So after that, the patient is planned for an MRI of the knee, and management would be planned accordingly regarding the ligamentous reconstruction. I hope you enjoyed the video. If you did, kindly like, subscribe and comment. Thanks for watching.